Hello, nurses. This is Lisa doing a podcast about nutrition. This is a very long PowerPoint, and I'm going to try to focus our information as I go through. But there are lots of things that we need to know when it comes to nutrition. Nutrition really is a key component of health. It is essential for growth and development, tissue repair and maintenance, cellular metabolism, and organ function. Scientific principles regarding nutrition and the role of nutrients in metabolism and health form a basis for the nutrition plan of care that you and the dietitian develop with your patients. Age, gender, activity level, medications, and disease processes all affect the use of nutrition, nutrients, and nutritional requirements. So when it comes to our knowledge base, we know that there are 6 essential nutrients, and that is carbohydrates, fats, and protein. Those are macronutrients. And then we have micronutrients, which are vitamins and minerals, and water is our 6th essential nutrient. So let's first talk about carbohydrates, and those are really starches and sugars, and fiber is included in carbohydrates. We use carbohydrates for energy. Usually carbohydrates will end in the 3 letters OS. So lactose is an example of a carbohydrate that's found in milk. Carbohydrates provide 4 calories per gram of carbohydrate. Examples of carbohydrate foods would be grains, and that includes corn. Corn is not a vegetable. Beans, while those are considered vegetables, they are very high in carbohydrate as well as protein. And all the snacky foods that we eat, chips, cookies, cakes, granola bars, oatmeal. Vegetables are even carbohydrates, fruits. We do need fiber in our diet, and it's recommended that people get 25 grams a day of fiber. And the last statistic I saw in 2017, only 5% of Americans get the recommended amount of fiber. Soluble fiber would be examples of whole grain. Soluble fiber really kind of turns into a gel throughout the GI system and the intestines, and helps clean the intestines as it goes through. And so examples of soluble fiber would be oatmeal. If you think of an apple, the inside part of the apple is soluble fiber. The skin of the apple is an example of insoluble fiber, which does not change when it gets into the moisture or the wetness of the GI system, and that helps push debris through our intestines. So examples of insoluble fiber would be a lot of vegetables or skins. So that apple skin is a good example. Celery, cabbage, all examples of insoluble fiber. And we really need a combination of both of those for best health. They help the bacteria in our intestines maintain a good balance. Proteins also are made from amino acids, and they are also 4 calories per gram. We do have a required daily intake of protein, and it depends on where you are in your growth stage. So really, babies and children who are growing require more protein than adults require. And adults require about 0.8 grams per kilogram of ideal body weight per day. Protein is composed of 16% nitrogen. The body uses nitrogen for building, repair, and replacement of body tissues. The achievement of equal nitrogen input and output is called the nitrogen balance. When intake of nitrogen is greater than output, the patient is in positive nitrogen balance. The body needs a positive nitrogen balance for growth, maintenance of lean muscle mass and vital organs, as well as wound healing. When output of nitrogen is greater than the intake, a negative balance occurs. Negative nitrogen balance occurs in infection, sepsis, fever, burns, starvation, and trauma. Fats. So fats are also known as lipids, and there are different types of fats. Fats provide 9 calories per gram, so they are more densely caloried. When we talk about different types of fats, the biggest thing to remember is that saturated fat is usually an animal fat, and an unsaturated fat is more liquid at room temperature. So right now the standard is that we limit saturated fats in the diet. I want to mention essential fatty acids here and talk about where to get them. So examples are linoleic acid and linoleic acid. Let me make sure I said that right. It's linoleic and linolenic acid. So those are the 2 essential fatty acids, and we need to get those from plant sources. So if you think about people who don't eat a lot of vegetables or unprocessed foods, they tend to not get enough of those essential fatty acids. We do need those fats for helping blood clotting, to help our joints be lubricated, our immune system. So we do need fat in our diet. I did put vitamins in with fats on the same slide because we have some different types of vitamins, water soluble or fat soluble. And water soluble vitamins are B and C, and we need those vitamins. B is very important for our nervous system. Vitamin C is so great for immune system and lung health. So if you have a patient with a lot of lung issues, you want to make sure they're getting enough vitamin C. Those water-soluble vitamins, B and C, we do not really store them for very long, and so we need those on a regular basis. Our fat-soluble vitamins, which are A, D, E, K, or ADIC, we can store in our fat, and therefore we keep them for a little bit longer time. These are the vitamins we also need to be careful that they can be overdosed on because we can store them. So sometimes people will take too much vitamin A and start to turn a little bit orange. But we need those. Vitamin A is great for immune system. So is vitamin D. We need vitamin K for clotting, and vitamin E also in there. They really help clear out what we call free radicals or tissue damaging chemicals that damage the cells and tissues of our bodies. And so I just want you to be aware of a little bit of differences between those water-soluble and fat-soluble vitamins. So our next micronutrient is minerals, and those are elements that are found in nature that help our biochemical reactions in our bodies. We do need examples: calcium, magnesium, sodium, potassium, iron, zinc, iodine. Those are just some examples that we need. We know we need calcium in our bones. We know that we need potassium and calcium and sodium for our muscles to move. We need iron to help carry oxygen in our blood. So minerals, are very important. And then we say water. We know we need water. It transports nutrients. We are made mostly of water. When we see people who are dehydrated, we know that infants and the elderly are more likely to be affected by water loss or dehydration. We need about 1 to 1.5 milliliters for every calorie of energy used. So that means somebody who is a marathon runner probably needs more water than somebody who is sedentary. And the old adage is pretty true that people can go about 3 days without water and 3 weeks without food, if you've ever heard that in the past. So last slide with our scientific knowledge base, remembering that digestion begins in the mouth with mastication, chewing, that the amylase in our saliva begins to digest starch, carbohydrates, and then in the stomach, food particles are mixed with hydrochloric acid, and the gastric enzyme lipase begins chemical digestion of fat. And most chemical digestion takes place in the small intestines, where they have different types of enzymes for different nutrients to break that food down so that we can absorb what we need. The small intestine is the primary site of the nutrient absorption, and even that first part of the small intestine, the duodenum, absorbs most of the nutrients there. Water and electrolytes are absorbed mostly from the large intestine. Intestinal contents move by peristalsis throughout, so that's the muscle movement of it kind of winding through the intestines. And I want to talk about the definition of metabolism. So the definitions of metabolism we'll use in class refers to all the bodily, biochemical, and physiological processes. Through metabolism, nutrients are converted into necessary substances for cell function. Two types of metabolism are anabolism and catabolism. Anabolism is the building of more complex chemical substances from smaller particles. Catabolism is the breakdown of body tissues into simpler substances. Although catabolism produces some energy, both processes require energy, which comes from food or stored sources. All macronutrients, carbs, protein, and fat, produce chemical energy and maintain a dynamic balance of tissue buildup and breakdown. Major metabolic processes occur in the liver. The liver also regulates energy through its control of glucose metabolism. Glucose is the primary and preferred fuel for the body. Liver and muscle tissues store glucose in the form of glycogen. The basal metabolic rate represents the energy needs of a person at complete physiologic, mental, thermal, and emotional rest after awakening. Total energy needs are based on the basic metabolic rate, plus energy needed for activity, energy required to break down food, and energy required for healing during illness. Energy balance occurs when energy intake equals energy output. When energy intake is consistently less than energy needs, which is a negative energy balance, a person loses weight. If energy intake consistently exceeds energy needs, a positive energy balance, a person gains weight. The body has a limited capacity to store carbohydrates as glycogen in the liver and muscle tissue for short-term energy needs. Remaining excess energy intake is stored as fat in adipose tissue. Protein is not stored. It is either used or converted to fat when consumed in excess. When total energy demand exceeds dietary sources, the body relies on stored energy, fat, and glycogen. Fat-soluble vitamins are also stored in limited reserves for a few months, and the body releases them to meet the needs when dietary intake is insufficient. I wanted to mention Choose My Plate and Dietary Guidelines from the government in here. They are making some changes to this website, and I have a feeling that as Healthy People 2020, as we move through that and into Healthy People 2030, that some changes will be made to dietary guidelines. But for now, we have to use what our expert agencies tell us that is best practice. And so this is just a great reference for patients right now. If you are talking to patients about nutrition issues. We know that nutritional requirements depend on stage of development, body composition, activity levels, pregnancy, and presence of disease. There are sociological, cultural, psychological, and emotional aspects to eating and drinking in all societies. Holidays and events are celebrated with food. Food is brought to those who are grieving, and it is also used for medicinal purposes. We also recognize there are cultural and religious food differences. Food is incorporated into family traditions and rituals, and appearance is often associated with eating behaviors. Nutritional requirements depend on many factors. Individual caloric and nutrient requirements vary by stage of development, body composition, activity levels, conditions such as pregnancy and lactation, and the presence of disease. Registered dietitians may use predictive equations that consider each of these factors as a starting point for estimating a patient's nutrient requirements. There are some people who have alternative food patterns, and they can be based on religion, culture, ethics, health beliefs, or concern about the environment. Patients' food preferences and choices may not meet nutrition recommendations based on the Choose My Plate or dietary guidelines. Optimal nutrition intake depends on balanced consumption of all required nutrients. So some examples of vegetarian diet, which consists predominantly of plant foods. We have a vegan, which is strictly plant-based only, and yes, vegans can get enough protein. They have to be very careful with their food choices. Some people will say they're vegan, but if they don't like beans, nuts, and other plant protein sources, they are not going to get what they need. But for the most part, people who are vegan are very careful about that. Ovo-vegetarian, those are people who eat plant-based, but they also eat eggs or egg products. Lacto-vegetarians, they are plant-based, but they have added milk or dairy products in with their diet. And to combine those, ovo-lacto-vegetarians eat eggs and milk. If we're talking about developmental needs, we know that infancy is very rapid growth, and they have very high protein, vitamin, mineral, fat, and energy requirements just growing. Benefits of breastfeeding include enhanced immune system, reduced food allergies and intolerances, reduced infant morbidity and mortality, and easier digestion. Infant formulas contain approximate nutrient composition of human milk. Infants should not have regular cow's milk during the first year of life. And solid foods should be introduced beginning around 6 months of age. This is about when they start to need iron in their diet. And so we have iron fortified cereals are typically the first solid food introduction. It is recommended that infants are introduced one new food just every 3 to 4 to even up to 7 days to watch for any allergies or problems with foods. And as the infant becomes older, into toddler years, they require fewer calories, but they still need higher amounts of nutrients per kilogram. School-age children, they're slower and steadier. They have a gradual decline in energy requirements. However, school age and even during adolescence, a lot of energy could be used if they're very active children, so that needs to be considered. One time we see a calcium issue is for young adolescent girls tend to not get enough calcium or iron, and so that can be an issue for that age group. And of course, we have special nutrition needs during pregnancy, which you'll talk more about, and family-centered nursing. Once adults are above 65 and older, they have similar needs for nutrients, but they have a slowing metabolic rate. And that slower metabolic rate really means that they don't need as many calories. So that is important to look at. We see a lot of overweight and obesity in our patients, and we know that those numbers are just increasing every year. There's obviously an energy imbalance between calories consumed and calories expended. Genetics are somewhat involved, metabolic and lifestyle factors. We use the body mass index, which is calculated from height and weight and is a pretty reliable indicator of body fat, although it is not the end-all be-all. The recommended body mass index is 18.5 to 24.9, and that can be used in assessment of patients. We do know that the rate of childhood obesity is actually starting to level off at this point, but I'm sure that will be watched going forward. One thing I want to talk about when it comes to nutrition and working with patients on nutrition is that you have to be very careful when you're making food recommendations not to talk about your own experiences. We need to follow best practices and recommendations from our expert agencies and expert co-workers like registered dietitians, and be very careful when talking about fad food diets, all those things with patients, because remember, nurses, most trusted profession, and if you say something, the patient will come back and say, well, the nurse told me that something really worked for her or him, and so it must be really good. So we have to be careful about that. And we have to really use those expert sources so that we can apply those nutrition principles and the basics, so what we know about growth and development and the patient specifically, We can help patient change dietary patterns. We can remember our own experiences in the past, patients who have required special diets, that type of thing. But we need to also remember there are a lot of emotional issues with eating, and it takes a long time to learn a new habit. So we really have to have perseverance when we're dealing with some nutrition issues with patients. So part of nutrition with patients is we're going to go to the nursing process and assess. And so nutrition screening, there is in Moodle a mini nutrition assessment. There is something called the Malnutrition Universal Screening Tool, a must. And it's if you're worried about malnutrition with your patient, you can always go through that tool. And always going to use what tools we can when we're assessing nutrition. We're going to get a diet history, a medication history, and of course we have that mini nutrition assessment. If the patient is at risk for nutritional problems, we can always ask for the patient to be seen by the registered dietitian for more in-depth assessment. Your textbook has some excellent resources for you. The focus patient assessment on page 981 and the diet history on page 982. Just make sure that we're assessing intake patterns and dietary history, any changes in weight, and we can actually learn quite a bit by looking at the patient's skin. Is very helpful. And if you indicators of malnutrition on 983 is also a good place to look, so that we can look for brittle nails, brittle hair. Do we see any swelling or just really dry, saggy skin? We can look for those things. We are assessing patients for conditions that interfere with the ability to ingest, digest, or absorb nutrients. Okay, so patients at risk include people with some congenital abnormalities, surgical revisions of the GI tract, patients receiving only IV fluids, older adults, infants, and other people who are malnourished. That would include people with eating disorders. So we assess for those signs of potential complications like we see on page 983. When we're looking at lab tests for assessing, we can look at a glucose. A normal glucose fasting would be between 60 to 100. A random blood glucose could be 60 to 160 or 140, I'm sorry. Others that are mentioned like electrolytes, albumin, not albumin, electrolytes, BUN, creatinine. We would look at those. We're going to talk more about some of those in another presentation. Albumin, which we talked about in skin integrity, would be something that we could look at for nutrition as well, because it's measuring protein. Some patients have dysphagia, which is difficulty swallowing, which can occur as a result to muscles and nerves, and sometimes from an obstruction, like a mass. Signs of dysphagia include coughing, change in voice tone or quality after swallowing, abnormal movements of the mouth, tongue, or lips, slow, weak, imprecise, or uncoordinated speech. The problem with dysphagia is that it can cause aspiration or inhaling into the lungs of something other than air. So dysphagia often results in decreased food intake because the patient is stopping to cough and eating slower, and they just don't tend to eat as much food. Whenever we worry about dysphagia, we are consulting the speech and language pathologist. That's who's going to help us with that. Diagnoses for nutrition would be deficient knowledge, imbalanced nutrition less than body requirements, diarrhea. When a patient has diarrhea, that means they're not absorbing all the nutrients and water from the food. Feeding self-care deficit, impaired swallowing, obesity, overweight, and risk for aspiration. When we're planning for our patients, we want to improve their nutrition status from whatever it is, and including the monitoring and evaluation to determine the effectiveness of our nursing interventions. Obviously, we want to individualize and create patient-centered interventions, and the goal of caring for patients with nutritional alterations is to first prevent any decline in status. So I'm going to say that again because it's very important. The goal in caring for patients with nutritional alteration is to first prevent any decline in status. So this is where we really need to individualize our planning. Patients at risk for compromised nutrition have a plan of care aimed at improving their nutrition status as well, recognizing that many factors can influence the priorities of a patient's overall care, and sometimes nutrition is lower on the list. When illness disrupts appetite or the ability to eat, we need to anticipate what is most important to help the patient achieve good nutrition. Patients and family members need to learn skills to administer nutrition therapies safely and effectively. While the registered dietitian is the nutrition expert on the team, it is actually your frequent contact with the patient that will make the most lasting impression. So when we are working with patients with food choices, menu planning, and dietary patterns, it's very those interactions are very important. We know that a high percentage of patients who attempt weight loss are unsuccessful and regain weight over time. However, when a medical physician, nurse, dietitian are all involved as a team and the patient is diagnosed as overweight or obese, weight loss efforts tend to be more successful. Successful weight loss plan involves sustainable lifestyle modifications, including physical activity, self-monitoring, portion control, and knowledge of energy content of food. One diet that is effective in weight loss maintenance, reducing blood pressure, and promoting overall health is the DASH diet, which is Dietary Approaches to Stop Hypertension Eating Plan, based on research by the National Heart, Lung, and Blood Institute. The DASH diet is full of fiber, by the way. Healthcare professionals not only need to be aware of factors related to food safety, but also should provide patient education to reduce risk for foodborne illnesses. And your textbook also has some pretty good resources here about food safety, and table 35.3, which is page 989, and talks about different botulism, E. coli infection, hepatitis, Clostridium foods, and remembering that most foods come from home canning that is done incorrectly. I know we hear about food recalls all the time, but still the most common cause is home preparation. So factors that influence nutrition for the acutely ill patient could be disrupted meal times, patients who are NPO for some reason, fatigue, discomfort, medications, symptoms associated with illness, and diets lacking in taste that are low sodium because they're not used to that very often. It is common for oral intake to decrease during periods of stress and acute illness, although keep in mind for some people, they will actually increase their intake because food will soothe them. And a lot of stress-induced hormones can either have an anorexic or lack of appetite effect or the opposite. So it is important to monitor their intake. One disruptive influence on intake in acute care is diagnostic testing. So some of those tests require the patient to be NPO or be on a liquid diet, that type of thing. Emotional stress also influences intake. Medications can affect dietary intake and changes how the body uses the energy from the food. So things that we can do for patients is to make the food look good on the plate, provide an environment conducive to eating, meaning offer to hand hygiene, providing mouth care. Sometimes you might need to administer an antiemetic or anti-nausea medication prior to the meal. Assist the patient with feeding. Sometimes they're just too tired to do that. Patients with dysphagia may need some liquids that are thickened, and so you have thin liquids, which are normal, nectar-like, honey-like, and spoon-thick liquids. You feed a patient with dysphagia slowly, smaller bites, and allowing the patient to chew thoroughly before taking another bite. Therapeutic diets include NPO or nothing by mouth, ice chips only, clear liquids, full liquids, soft or mechanical soft diet, which is usually lower in fiber, a low fiber diet or a high fiber diet, low sodium, low cholesterol, and then thickened liquid diet, and also a regular diet. If you have a patient with vision issues, what do? You make sure that they know where the food is on the plate. They can use assistive devices to eat, and they will probably need some assistance for that as well. Okay. So what do we do for people who are unable to meet their nutrition needs orally? We're going to first talk about tube feedings. So enteral nutrition is the use of the gastrointestinal tract for the intake of nutrition. According to this definition, oral intake is also a form of enteral nutrition. However, in a clinical setting, the term enteral nutrition is only used when nutrients and fluids are being administered into the stomach or gastrointestinal tract via a feeding tube. Nasogastric feedings are delivered through a feeding tube introduced through the nose and into the stomach. Nasointestinal feedings are delivered through a feeding tube inserted through the nose, passed through the stomach, into the duodenum or the jejunum. When patients have nasopharyngeal obstructions or are not candidates for a nasally placed tube, or when the enteral nutrition is anticipated to be longer than 4 to 6 weeks, a feeding tube may be inserted directly into the stomach or the jejunum. So you can look at a comparison of enteral feedings in your textbook, and that is table 35.5, which is page 992. So there are lots of different formulas available to meet patients' needs. When making a decision regarding access, the healthcare provider considers the patient rate of gastric emptying, GI anatomy, risk for gastric reflux and aspiration, as well as the anticipated duration of requirement for enteral access. Ensure that enteral feedings are correctly connected to an enteral feeding tube. The gold standard for determining tube location is radiographic confirmation, X-ray, CAT scan, ultrasound. Assessing the color and pH of gastric aspirate for ongoing monitoring of tube location is shown to be effective and less costly. And we'll look at those skills in lab. You administer feedings into the stomach via a G-tube or a PEG tube using gravity bolus in small volumes, or it's on a pump. So gravity bolus means that just the bag is higher than the stomach. You're adding the formula into there and letting it run slowly through there. And a pump is, you're going to be setting it as so many mLs per hour. Formula should be kept at room temperature. It needs to be shaken in the can before it is poured into the tube feeding device. The head of the bed should be at a minimum of 45 degrees. If the patient needs to remain supine for some reason, you can put them in reverse Trendelenburg position. Their head needs to be higher than their stomach. There is a high risk of aspiration if they are laying lower than 45 degrees. We aspirate fluids out of the tube and measure the pH to make sure that it is highly acidic, like you would find in the stomach. Some facilities may have a different procedure, and so you would check their policy and procedure at each facility. You also need to check gastric residual volume every 4 to 6 hours, and again, that's a facility policy. So you add 10 to 30 milliliters of air and pull back and see if you can pull back some formula that's in there that's still undigested. If the residual is over 200, we should be concerned, because what will happen if we add more tube feeding? It needs to be, we need to make sure that gastric motility is happening, because if we keep adding more and more tube feeding, it's just going to be, the patient's going to end up throwing it up and have a chance for aspiration. It is very important to take measures to prevent and monitor for feeding tube displacement. Daily cleaning and evaluation of the site helps detect problems. Take measures to prevent displacement of the feeding tube, which could include taping it to the abdomen or tucking it into clothing for security, or even applying a binder if necessary. For example, if you have a patient who keeps picking at it or pulling at it. We will not talk about parenteral nutrition in this class. You will learn that more next semester. Parenteral nutrition is nutrition that's given through IV access. Really just monitoring and doing a lot of education with patients. Why do they need protein? Why do they need to balance their carbohydrates and fats? So just being aware of that. Lots of education opportunities following those very much expert sources. When we talk about patient outcomes, one of the biggest outcomes that we'll use is patient weight and patient intake and output record. Definitely want to look at labs. If we started out with those, we would compare labs, keeping in mind that, for example, an albumin, it can take many weeks to months to get an albumin to change. So that is not something we're normally going to see a big change of in acute care setting, but we would be able to monitor that more long-term, obviously in long-term care. So again, lots to learn in nutrition. Remember that when we are giving tube feeding, we're verifying the tube position. We're ensuring that we have the right patient, the right formula, and we're using the right tube for the patient. The head of the bed is at a minimum 45, I like 45 degrees if possible. So keeping all those safety things in mind. Definitely want to make sure that we're using tube feeding and all the equipment as manufacturer directions, that it is plugged in, all those things. We want to make sure that when we're using those bigger syringes, that we're keeping those clean. We're flushing the tube feeding line every time we give medications, and we should flush with at least 15 mLs of water, but that may also be a facility policy that you would follow the facility policy as well. And that is it for nutrition. And thank you for listening.